Hola, ¿cómo están todos? Bienvenidos a un episodio más de un café con el experto. En esta ocasión yo tengo el placer de estar acompañado, porque estamos justo en el marco de Citic 2024, de un gran amigo que habla inglés, entonces voy a cambiar a inglés. And this is my pleasure to have here with me. I can introduce you as a friend. Can I say a friend?
Absolutely, please do.
Thank you, Philippe. Philippe Lallier. Philippe Lallier is Canadian. Philippe Lallier is an interventional cardiologist, but also he has many jobs and charges in his CV. But right now he's the head of a preventive cardiology department. That for an interventional cardiology, it is not that common, but this perspective of having both is very interesting, and I would like you to know Philippe, and also I would like to talk about this redefinition and building of prevention. So Philippe, thank you for being here. Talk to us just some details of how's your life. You grew in Canada, in Montreal, or were you somewhere else, or how was it?
Yeah, so my personal history is that, of course, I grew up in Montreal. I've developed interest for medicine when I was very young. My mother was involved in the field of healthcare, and so I developed interest in that, and then eventually I became a doctor. In the field, in becoming a doctor, I was always kind of very open to different perspectives. I didn't like the idea of being so focused, but nevertheless, I became an internal medicine specialist, and then a cardiology specialist, and then I went into interventional cardiology, and then, of course, I became an interventional cardiologist in a healthcare center that is very focused in cardiology. It's a cardiology institute in Montreal.
Mm-hmm.
It's the Montreal Heart Institute. So when I came back from fellowship, I did my fellowship at the Cleveland Clinic in the US. I was heavily involved in acute coronary syndromes and complex angioplasties. And so I became rapidly, let's say within 5 years, I became director of the coronary care unit. So I was always involved in patients with atherosclerosis, with coronary care, and I developed a heavy interest in atherosclerosis. But to me, atherosclerosis stems from a very early age all the way to dying of it, so end-stage disease. So to me, this continuum always made me think that it is not necessarily the right way to think about it by doing complex angioplasties only, because this is one small part of it.
Mm-hmm.
And my vision of atherosclerosis is very global, and I think it stems from very early on. When I was at the Cleveland Clinic, we did a study where we did intravascular ultrasounds in newly grafted hearts, so hearts from people in their 30s. And we found commonly atherosclerotic lesions in these patients. So this was very early in their lives. So it stemmed a question to me that what can be done very early in order for the disease to not progress and not develop in patients to have very complicated problems later on. My father died of a heart attack at 53. So this is also a part of this situation where I wanted to think about it in a global perspective as opposed to very focal stenting or very complex angioplasties. Don't get me wrong, I love doing mechanically supported angioplasties with LVADs. I love doing complex patients with shock. I love doing CTOs. I love doing complex interventions like that. I think this is they're very important, and rotoblators and complex interventions like that for very calcified lesions, very advanced lesions. But to me, I've always expected my patients to have appropriate knowledge of what they can do in order to change the disease path, to change how the disease would evolve eventually. And now I'm in a position where, after a while being involved in being a director of the CCU, then director of the cath lab, I'm heavily involved now being director of prevention. But it's not something new; it's something unusual for an interventional cardiologist. Someone who has developed a network of care for primary angioplasty, for example. I am known for that in my region. But I also have always thought that we needed to have a global approach, including non-medication-based prevention. And so by doing this, I am now involved in a global perspective about atherosclerosis and cardiovascular prevention. And my center, it's a hospital-based organization, obviously, but I'm thinking, I'm planning to develop an entire program around the hospital to reach kids that develop the disease early, as I mentioned before, but to reach them, to allow them to understand what's good for them and what's good for their health, and make choices early in their lives when they start making choices, and then reaching young adults that can actually make decisions and make specific changes in their lives, and then take care of patients who have had complex angioplasty and so on, and help them avoid recurrence and avoid the disease progressing. So this is a global perspective for me, and I like to see prevention as a primordial prevention for people who don't have any risk factors, secondary prevention for people who have risk factors but we don't want them to develop the disease, and for people who have the disease but we don't want the disease to progress. So this is how I see it, and this is how we are developing a global program from kids in their schools and in the summer camps to people who have young adults who have children and so on, to people who have the disease and need rehabilitation, and then have, of course, medications and so on to improve. And sometimes we can reach from low sugar and exercise to stents for culprit lesions that we have seen recently in the literature. So very broad perspective.
Yes, for sure. And taking into account that you are an interventional cardiologist and that you have to treat acute patients, for example, acute MI, you can find, because you're very involved in intravascular imaging also, and you're an expert and you run a lot of trials within intravascular imaging, so we can, how can we, or what's your point of view about the future perspective of these plaques that are not obstructive right now, that could be changed in terms of how vulnerable they are? I mean, non-obstructive lesions that you find when you treat another lesion, but this is a mostly important preventive cardiology or cardiac prevention, secondary prevention that you have to do. Do you think that we're doing bad things? I mean, we have these levels of the threshold for cholesterol, LDL cholesterol, okay, but when you find that something is growing, and it is not the culprit one, but something is growing there and is more vulnerable than the other patient that has also the two vessels disease, the same scenario but with a vulnerable versus a non-vulnerable patient. This idea is not in the guidelines right now. We don't have. We have the. I mean, you are putting those patients, both of them, in the same box, and those are different patients with different risks. Do you think that, as an interventional cardiology that is involved and in charge of a preventive cardiology department, should you suggest your doctors, your people, to change their way of thinking, or to improve the treatment in those patients that are at the highest risk?
So you just mentioned two things that are very important: the lesion that is vulnerable and at risk, and the patient. I think it's the combination of both that will actually make the best evaluation of a given situation for a given patient. To your point, that if we find a patient and we have an opportunity to interact directly with a specific individual, let's say in the cath lab, we as interventional cardiologists have a duty and have instant credibility to convince them of many things. Therefore, because of this opportunity to have an interaction with the patient, we should do the best we can to identify lesions. Outside of, and then of course when this happens, we need to have the tools in order to say whether a given lesion is vulnerable, and we need to have the randomized control data to see what exactly should be done for those patients and what's the best option for that particular lesion to not evolve into a critical MI, for example. So that's one thing. But if you look at the global picture, the number of patients in whom we will have access to the coronaries in order to perform intravascular imaging, for example, is very, very small compared to the amount of patients that have the problem. And most likely, most of the MI patients that we see are new patients that we have never seen before. So therefore, it's very important to understand that the impact that we can have as an interventional cardiology community and as a hospital-based group of people involved in care of patients is the global picture that's important in addition to the given patient. So you have a particular obligation towards a given patient when the patient, you have access to him in a given clinical situation, it's an acute scenario. But you also have, and I think doctors don't feel that as much, we also have an obligation towards the global population. And we have credibility, we have knowledge, we should leverage that in order to get access to patients and have them to the population, not patients, to population, in order to prevent the first event. Because for MI, for example, the first event is sudden cardiac death in 30% of patients. That's why prevention is so important.
Yes.
And I was telling the story of my dad. My dad never had a problem before, died suddenly. That's what you want to prevent.
Yes.
And you're not going to be able to do this in patients in whom you don't have access, let's say, to the coronaries in the first place.
And we share this because as I said, we're friends. You know my history also, and part of it is that my dad died at 51 years old. He has diabetes. That's a different story. He has multivessel disease. At that time, without the advances in the technology, was very difficult to treat him. But how could you? I'm going to do a provocative question. How, as my friend, what's your best suggestion for me to prevent a heart attack, being a son of a man that died at 51 from a heart attack?
So I think we need to divide this into very technology-based suggestions and global suggestions. You never had a heart problem yet, so it's very important to understand that 5 situations will make you at very low risk of developing a heart attack, globally speaking. That is healthy eating, very limited ultra-processed foods, limited sugar, limited animal fat, mostly vegetarian. That's very well known, and it's good for the heart, it's good for cancer, it's good for the brain. Second is that you need to exercise on a regular basis. So this is, of course, somewhat difficult with our schedule.
Yeah, but you have to.
But I would strongly suggest you exercise on a regular basis, almost every day, at least a 30-minute exercise, no matter what you do, just a little bit of exercise. Sleep well, also quite difficult, because we have crazy schedules, we do acutes in the middle of the night, we travel a lot, very difficult, but a healthy sleep is very important. And then, of course, you not smoke. I take it you're not smoking, so it's very important. So if you do all of this, your chances of not developing the heart disease is probably 80%, more than 80%. So very important you understand that the basics should be there. In addition to that, now you have a situation where you have a heavy family history, partially explained by socioeconomic factors that, of course, diabetes was an issue, not necessarily perfectly treated, but you also have genetics. There are numerous now multi-factorial risk factors based on genes. There are possibilities to look at your blood and find biomarkers that will be problematic, imaging biomarkers that can be helpful in order to decide, and then of course look for ischemia maybe, but to be fully honest, it's not ischemia that's a problem, mostly it's atherothrombosis.
Yeah.
I mean, most of the data is suggesting that this is the case.
So you said imaging markers. What kind of imaging marker do you suggest to me? Is it a calcium score?
So
is it a...
Yeah, so if I would see you in my clinic, and you're my friend, of course, this is a bit of a bias, but nevertheless, I would definitely do a stress test, see if you have ischemia. Okay. And I would do probably anatomic evaluation to phenotype your arteries and decide on this basis what level of treatment you should get. Do you need no treatment? Do you need treatment for inflammation? Do you need treatment for cholesterol? How intense should the cholesterol treatment be? And then, of course, what else can we do? Do you need revascularization because you have silent ischemia and a broad sense that it's actually involved the left main, for example?
Yeah. So and if in terms of the LDL levels, I never had a heart attack before. I've never had a stable CAD. Should I be at which level as just having this risk factor of the genetics?
So the idea is that the genetic factor needs to be identified whether it is associated with other risk factors. Let's say, is it associated, for example, with diabetes? Is it associated with smoking? Is it associated with something else? Because oftentimes the family history is, of course, partly the lifestyle of the family.
Mm-hmm.
Now, if this is not the case, and your dad was thin, he was exercising on a regular basis, and so on, then it depends on whether you have the disease or not. Then, of course, it's very important to determine your phenotype. And if the phenotype says you have a significant disease, then, of course, we need to go for very strict LDL levels, let's say below 1.4, below 1.8 for sure, but ideally below 1.4.
So do you think that the risk scores to people like me, that maybe if I measure my risk score, I mean,
it's low.
It is low. It is low. It depends on the age also, and I'm going not to be low in a few years, but I'm still low in the low risk factor. But if my LDL is, do you use milligrams or millimoles?
Millimoles.
Millimoles. Well, we use milligrams, so I don't know the exact conversion, but if I have 130 of LDL, I'm completely out of the threshold for someone that has to be in a secondary prevention. This is not secondary prevention for me. This is primary prevention. But if you demonstrate me that I have maybe a very small plaque, but a plaque, do you put me in a secondary prevention? Or
it's somewhat of an empirical decision to do that, and I would try to balance your true risk compared with your anatomic risk, and then I would do things together. But we have strong data for calcium scoring, for example, so definitely I would obtain calcium scoring. But I would also probably, in the sense of phenotyping, because you're young, do also a true and formal coronary scan as an exception for someone like you.
Yeah.
Not for everybody, but as an exception for someone like you, because the component that's genetic is very difficult to integrate into the algorithms, into the risk scores.
For sure. And do you use, because we are talking, I told you my story, and as a friend, maybe you can do that. But I mean, in an institution, I mean, in a global situation, how can you detect that?
Well, of course, now is because in a global situation, you use the scores.
Still the scores.
We use the scores, and we use sometimes both the European score, the American score. We try to ponder different factors, and of course, I myself, when I find someone that's at high risk, then of course I go for phenotyping, whether it's only calcium scoring or formal coronary scan. Then of course it's a matter of decision, and we're in the gray zone.
For sure. I'm sorry that I have consultation for free right here. But
that'd be my suggestion. And then, of course, if we find a significant disease, for example, then I would empirically put you in a secondary prevention because of the high risk.
And this was because a lot of people is in the middle of the same situation as me. But in this podcast, we frequently ask at the end of it. We are approaching to the end, but if you want to share a case that you can remember and you want to share because it was a case that marked you, that changed your life, that you remember because it was a very, very important case in your through your life, and sometimes sharing this kind of cases that you remember, because if you remember it is important and it's shareable. So could you share a case that marked your career, your life?
Well, I would say there's a group of cases where I see patients that have basically no traditional risk factors. and they happen to have significant disease. They happen to have an MI for no reason. You look at the profile; they're very low risk, but nevertheless had a major infarct. I have a given patient that I'm going to see again soon. The guy was involved in a SWAT team, super trained, extremely in good health, 40, not even 40, 38. No risk factor for coronary, and had a major anterior MI with an ejection fraction of 30%. This kind of patient are very, very striking. And it's very frustrating because they could not have been identified initially as being at risk. And this is the kind of patients that we want to identify and help. Of course, we can develop networks of care to take care of the MI when it happens. It's important. But more importantly, it would be for him not to have the MI in the first place. And that's the situation where we need to develop better algorithms based on different risk factors. The risk factors currently are evolving. Of course, cholesterol is important, diabetes is important, cigarette smoking is important, but there are numerous new risk factors that are key now that we need to incorporate in those. For example, ambient air pollution is becoming as important as cigarette smoking. The risk factor, for example, of cholesterol is completely outweighed by the risks, nutritional risk, dietary risks. For example, the climate change with very high temperatures are becoming extremely important in preventing heart disease. Microplastics, we find microplastics in coronary plaques now. So these are things that never happened before, and the landscape of risk factors are evolving. And to me, this is something that as cardiologists, we cannot be in an ivory tower. We need to look around what's happening, and we need to confirm that. We need to include these in our algorithms for prevention. For sure.
Very interesting. We're almost at the end of it. How did you see the progression of the Citic course? Because you developed, and I'm asking you because I went to your course many years ago when I was at the fellowship, because it was Montreal Life, right?
Yes.
Yeah, and this was an amazing course. But how do you? Because you're a frequent flyer, I say, when you've been here for more than 4 years.
Yeah. So for me to come here, as you just mentioned, it's my 4th year. I make it a point in coming because I'm extremely impressed with how things are run here.
Oh, thank you.
You organize this as a people's meeting. You organize the meeting for the people who come to the meeting, and it's something that you can feel. You see the faces, everybody is happy. You see the exchange of information, not necessarily if I'm top down. There's also lots of exchanges between the rooms, which is something that is, for me, is a key marker of a good meeting. And the atmosphere that you feel here, the camaraderie between people you don't really know but come to you, discuss wholeheartedly about their situations and their particular issues, is something that is incredible, because the knowledge transfer between the people who come and ask you questions and you sharing your experience from your part of the world makes it super interesting. And it's a big congratulations to you and your organization. It is impeccable.
No, thank you, Philippe. I know that behind that is the friendship that is talking.
Very objective, very objective.
Thank you very much. Well, thank you for being here, and you'll be in the next years, if you accept, you'll be invited all in the entire in all the editions. You'll be here.
You can count on my full support.
Thank you very much, Philippe. Muchísimas gracias a todos. Gracias por estar con nosotros. Definitivamente una plática muy interesante en esta perspectiva de un cardiólogo intervencionista que hace también medicina preventiva, y que a través de un caso, muchas veces que ahora le pedí una opinión del mío, aprendemos mucho, ¿no? Le agradezco muchísimo a Philippe estar con nosotros, a ustedes por su interés. Por favor, si quieren seguirnos, activen las notificaciones. Nos vemos en la siguiente edición, todavía aquí en Citic 2024. Les pedimos que denle like, activen las notificaciones y nos sigan, y ojalá puedan venir a vivir esto que dice Philippe, que se siente, que realmente se siente y se puede respirar mucha educación. Muchísimas gracias y hasta la próxima. Thank you, Philippe. Thank you.